Good afternoon, everyone. My name is Jacob. Today I'll be giving you a speech over why nitroglycerin is no longer contraindicated in inferior STEMIs and how we can adapt our treatment here in the future. So in the past, the thought's been that all STEMIs should be treated different, and inferior STEMIs are different than anterolateral and so on. And the new studies have shown that rather all STEMIs are prone to the same side effects, and they should all be treated equally, and as well as assessed for the same kinds of side effects and hypotension and dysrhythmias and things along that line. So in the past, we always thought that every inferior STEMI caused hypotension, it couldn't get nitro, and couldn't get any kind of vasodilating agent, when in fact, now we've realized that all STEMIs are susceptible to hypotension and bradycardia, and all those side effects we used to think were solely inferior STEMI problems. So how we're going to do this in the future to fix it is assess all STEMIs thoroughly, assess them for the same side effects, and treat them as your protocols tell you to. That means if anterolateral is hypotensive, give them a fluid bolus, be cautious with nitro. If inferior STEMIs are hypertensive, you can give them nitroglycerin to lower their blood pressure as well as increase blood supply to the heart and everything along those lines. So a study done by Dr. Keith Wesley, posted in GEMS, showed that all STEMIs are actually prone to the same side effects and same symptoms rather than just inferior STEMIs being prone to those hypotensive episodes. So, since treatments are evolving, we'll discuss how we can more effectively treat STEMIs. So the past thought was that nitro was for pain only, and that's all we used before, reduce the workload of the heart, when in fact we can use fentanyl for the pain and then use nitro at a low dose on a drip to hopefully increase coronary vasodilation and therefore increase blood flow to the heart and oxygen supply. So this opens up the myocardium, therefore increasing blood flow. If you get it too high, you can cause vasodilation systemically and therefore cause the hypotension we've seen in the past, but you can always do a fluid bolus to fix that and correct that as well, so it's nothing to worry about by any means. But fentanyl overall is a better painkiller and overall more effective and safer. So according to a study from www.who.int, heart disease is still the world's top killer. So the new focus EMS needs to be on the rapid ID of STEMIs as well as proper transport to the appropriate facility. Here in Columbia, it's not too big of a deal. You're more likely going to the right facility. Either way, it's a class 1 STEMI center. But out rural, they've always thought that helicopters were preferred transport, when in fact, if you can drive them faster than a helicopter can fly them, driving is the preferred option. Because overall, the main goal is to get them as fast as you can to a reperfusion center and to get a proper cardiologist taking care of that patient. So also, in the field, we need to acquire 12 leads within 5 to 10 minutes of being on scene for anybody who might have a STEMI. STEMI means bringing the monitor in the house, assessing the patient quickly and getting a 12 lead, and find that STEMI early on so you can get transport to that facility faster. So, a study done by www.ncbi.nih.gov showed that quick 12 leads by EMS decreased mortality by somewhere around 66%, I believe. So that's a big number to help us focus our treatment and go that route. So also, while nitro is important, aspirin still needs to be on our top priority list of what to administer and to get on board as fast as we can. So aspirin is something we always have thought of as an antiplatelet in a way, just inhibits the coagulation of the platelets, therefore decreasing the risk of secondary injury after the first clot's already in the heart. So aspirin, we get that on board, preferably as fast as we can with chest pain patients, anything with this might have ACS symptoms, or any kind of coronary disease issue. So, a study done by Tulane University showed that aspirin should not be administered for at least 2 hours prior to other NSAIDs. So if someone took their at-home ibuprofen, the effectiveness of the aspirin won't be near as effective as how it should be until 2 hours after the ibuprofen was administered. So that's something I didn't know about prior, but I guess NSAIDs can be stacked on top of each other within 2 hours and be effective. There's no side effects to it, just the effectiveness goes down. So our final point today is vasopressors and STEMIs. Always be ready to utilize one as needed. Fluid first, and then go to your vasopressor, unless it's cardiogenic shock, then you might be limited on your fluid you can administer. In the past, we've always used dopamine, whereas now norepinephrine and epinephrine combined are kind of the go-to, safer, better use, and less tachydysrhythmias when giving them. But always ensure preload is full with that fluid bolus and treat that first as well. So the epinephrine, a lot of times it gets given for SA node effects. When it affects the heart rate, you get bradycardic, and you can mix epinephrine in with the norepi and get their heart rate up as well as their blood blood pressure. So to conclude today, we talked about STEMIs overall and how they're no longer the past thought process of inferior STEMIs always have hypotension is no longer a thing, and how all STEMIs are susceptible to the same side effects, as well as we went over aspirin, getting you on board quickly, getting 12 leads in the field fast, and initiating transport as fast as we can to the right center, as well as some vasopressors and some knowledge about that and how to effectively use it. So overall, hope you guys learned something, and I appreciate your attendance today. And here is a reference of the heart if you need that afterwards.